morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to yet another edition of ACNS webinars. The speaker for the first session of today is our special guest from Kigali, Rwanda, Dr. Claire Karekezi. Dr. Karekezi started medical school in 2002 when neurosurgery did not exist in Rwanda. Neurology and neurosurgery were taught in classrooms, but there was no formal neurosurgery training and a single practicing neurosurgeon in the country. This CAS neurosurgical care was provided by expatriate surgeons from South Africa and Cuba, and today Dr. Karekezi is the first and only female neurosurgeon in Rwanda running a neurosurgery unit at the Rwanda Military Hospital, one of the country's largest tertiary referral hospitals. Dr. Karekezi did her residency at the Rabat Center, funded through the Rwandan Ministry of Health, and completed neurosurgery training. She was further trained through a visiting fellowship in neuro-oncology at the Brigham and Women's Hospital and a clinical fellowship in neuro-oncology and skull-base surgery at the University of Toronto Western Hospital. We are extremely honored to have her today at our webinars, and she'll be talking about neurosurgical plasticity, adapting to resources. The speaker for the second session of today's webinar is our honored guest from China, Professor Tao Wang. Professor Wang is a professor, doctoral supervisor, and chief physician at the Department of Neurosurgery at the Peking University Third Hospital, Beijing, China. He is also a visiting professor of the Westmead Hospital, University of Sydney, Australia. He is the vice chairman of the ischemic stroke surgery branch of the Stroke Expert Committee of the National Health Commission of China, and also of the cerebrovascular disease high-risk group management branch, Chinese Stroke Society. He is one of the best carotid surgery experts in China and has more than 4,000 cases of carotid endarterectomy and more than 100 cases of complex carotid body tumor resections. He is a noted author who is also on the editorial board and is a reviewer of at least 13 academic journals. And we are extremely honored to have him today at our webinars, and today he'll be talking about carotid artery stenting versus endarterectomy, a rational choice of cases with critical carotid stenosis. The chair for the first session of today's webinar is an honored guest from Colombia, Professor Andres Rubiano. Professor Rubiano is a professor of neurosciences and neurosurgery at Bosque University, Bogota, and he is also the chair Neurological Surgery Service, Valle Salud Clinical Network, Cali, Colombia. He is the president of the Colombian Association of Neurosurgery and the president Neurotraumatology and Intensive Care Chapter of the Latin American Federation of Neurosurgical Societies. He is also the chair of the International Committee Neurotrauma and Critical Care Section, American Association of Neurological Surgeons, and the co-chair Neurotraumatology Committee, World Federation of Neurosurgical Societies. He is the International Director, Brain Trauma Foundation, USA, and Vice President of the Global Neuro Foundation of Switzerland. We are extremely thankful to him for accepting our invitation to chair the session of Dr. Karekezi. The chair for the second session of today's webinar is our honored guest from Canada, Professor Ashish Kumar. Professor Kumar is an assistant professor at the Center of Cerebrovascular and Endovascular Neurosurgery, Sunnybrook Health Sciences Center, University of Toronto, Canada, Ontario. He was a past fellow at the Fujita Health University as well as the University of Toronto, Canada. He is the fellowship director of the Advanced Microneurosurgery at his institution and is also the vice chair of the Inclusion and Diversity Division of Neurosurgery. He is a part of several novel projects in his institution which are contributions to the development of professional practices, educational scholars programs 2020-22 and creative professional activity, Sunnybrook Neurovascular Pilot Project, which are aimed to create quality educators as well as quality education in neurosurgery. He won the Peter Boyd Teaching Award for the best teacher last year. He is a hybrid neurosurgeon who specializes in the management of aneurysms and other cerebrovascular diseases. We are extremely grateful to him for accepting our invitation to chair the session of Professor Wang Tao. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and all the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin, who is here. He is also the Vice President of the ACNS, and we are extremely grateful to him for broadcasting this on the WeChat channel. And with that introduction, I would like to hand over this platform to our first chair, Professor Andres Rubiano.
Thank you, Dr. Raya, for the kind invitation, and also to Professor Bean and Professor Kato for this great platform of sharing experience for several regions of the world of high importance and highlighting how these many experiences and efforts can be like an interesting pathway for many neurosurgeons worldwide. So for me, it's an honor to be here participating and introducing the talk of Dr. Claire Karekezi. Dr. Raya already mentioned the CV from Dr. Karekezi, and she's going to speak about neurosurgical plasticity, adapting to resources in the frame of plasticity, understanding how we need to evolve and also how we need to adapt to different conditions. Dr. Claire has been working in Rwanda in many topics, specifically mostly in neuro-oncology, as he has been with an excellent of training in this area, and also in trauma with some experiences that we have been working together in the field of how to improve and adapting resources in areas in order to move forward a higher quality of care in neurosurgery that is deserved not only for regions that have more resources, but transversal to all the regions of the world. So this is also in the frame of the World Neurosurgery concept that is a born subspecialty in the area of neurosurgery, and the World Federation of Neurosurgical Societies and all the continental societies and regional societies are now in the process of promoting this effort worldwide. But we understand sometimes even conditions in order to improve care of the patient. So I am really honored to introduce and also discuss the presentation of Dr. Claire.
Thank you so much, Professor Raj. I was saying thank you for the ACNS Education Committee. Thanks to Raji who reached out to me, to Professor Kato and everyone, and Professor Rubiano for the kind introduction. So I chose this topic because I'm still pretty young in my field. So I'm at my 3rd year and a half of practice since I finished my fellowship. So I just felt like I can share about my experience, how I started my practice in Rwanda, and what have been my wins, my challenges, and if it can help all of us sharing and exchanging. So the title of my talk today is Neurosurgical Plasticity and Adapting to Resources. As they said, I'm a consultant neurosurgeon at the Rwanda Military Hospital. I have no disclosures. I come from this tiny little country, is in East Central Africa. It's called Rwanda, with 26,000 square kilometers, but it's one of the most dense countries with 13 million people right now. But we have beautiful capital city, Kigali. We have beautiful hills, which gives us the land of 1,000 hills. We have nice species of mountain gorillas, the rare species that are remaining in the world, and we have a wonderful coffee. So I invite you all. I hope to host some conference or to in the future to just have some collaboration and have you in Kigali visiting us. So how about Rwanda neurosurgery? So in the past, before 2007, and if you heard Professor Raji, I started my training in medical school in 2002. So in 2002, we had no Rwanda neurosurgeons, and the Scouts neurosurgical care was provided by experts. So we had experts coming from South Africa and coming from Cuba. So in 2007, we had our first CT scan, and the first Rwandese neurosurgeon who trained in China started his practice in 2007, and I was almost about to finish my medical school. So we had our first MRI in 2010, and about 2011, we had 2 neurosurgeons for 11 million people. So all neurosurgical care was provided in the capital city, Kigali, and the rest of the country will drain to Kigali. So the local training was started in 2012. You will understand on the next slide why I had to get out to train. And then by 2022, right now I'm speaking, we have 6 neurosurgeons for 13 million people. We are still all practicing in the capital city, Kigali. Since we started our neurosurgical training in 2012, there have been 3 neurosurgeons trained locally. So, and we have been taking residents. Up to now, we have six residents, and we have 2 programs. So this is the University of Rwanda, and the COSEXA is the regional program for Eastern, Central, and Southern African countries. So by 2022, 6 neurosurgeons all practicing in the capital city, Kigali. We practice in 3 main hospitals. My hospital is the RMH Rwanda Military Hospital, which covers the whole eastern province of the country. So it's about 4 to easily 5 million people joining to me. So in the whole country, we have about 6 to 7 scanners. We have about now 5 MRIs in the whole country, and most of the imaging facilities are in the capital, but scanners have been disseminated in other districts. So about education, as I said, 2007, 1 neurosurgeon, 0 resident, no local training. About 2013, I would say 2 neurosurgeons, they had 3 residents who are the ones that finished and joined the 2, and I came to join the group. So we make 6. So we've been recruiting a resident. We have 2 programs, and so far we have no fellowship programs. So in my early age, I had 2 exposure in neurosurgery. The first one was in Sweden in 2007. And that time I was in my 5th year of medical school. So I got the first exposure, and I think that's the time I decided to become a neurosurgeon. But by that time, remember, we barely had our first neurosurgeon who started practicing. So he wasn't really well established, and training in neurosurgery was almost impossible. It was almost impossible in Rwanda. It was impossible in the neighborhood countries. So one had to figure out where to go. So I started digging. It took almost 3 years. You can see that I started my training in Rabat Center in 2011. So I stayed there from 2011 to 2016. I believe the Rabat Center came as a solution for African countries, and some of the trainees also will go to South Africa. So South Africa has also contributed, and later many other countries joined. So so far we have many training centers in Africa, and almost many countries have their own training in neurosurgery. So the Rabat Center gave me a comprehensive program in neurosurgery, and I believe it prepared me to come back to Rwanda, but it also opened doors to go outside and to go abroad. So from here, I did a short training at the Brigham and Women Hospital. It was more of observership, and I spent there almost 4 months observing in neuro-oncology. And later that led to a clinical combined fellowship in neuro-oncology and skull-based surgery at the University of Toronto, Toronto Western Hospital, where I had more exposure. And since it was a clinical fellowship, I believe it shaped me even more. It prepared me to be ready to come tackle some of the issues in my own country. So I finished my fellowship in 2018. And since January 2019, I earned the position at the Rwanda Military Hospital. So when I started at the Rwanda Military Hospital, there have been some neurosurgical consultations that were offered, but they really never had a permanent neurosurgeon. And there was no single neurosurgical procedure that was offered there. So I go there, and it was, I believed it was a little bit challenging for me, because I was, oh my God, what am I going to be able to do? How am I going to be able to even operate a chronic subdural or an epidural? For me, it seemed to be impossible. So from day one, it was about adjusting to what I had. So what did I have? I figured out that there was a Mayfield head holder, which was weird, not having almost all equipment, but having a head holder. And I made sure I got 2 sets, but initially it was 1 set that I split into 2. And I got 2 Hudson braces, a couple of bipolars, and I got jiggery saws, and I was able to do some craniotomies. So when the craniotomies started, everything was a little bit complex and complicated because I had to get, trust from the team, be sure that the team can help me proceed. I was working alone, no resident and no any other help. So I will do the surgeries, I will follow the patient myself, I will discharge the patient myself, I will tune the patient myself, I'll do the paperwork, and I'll do everything. I had an access to an ENT microscope, but I abandoned this because maneuverability was a little bit difficult, and I didn't find it very sterile, and I could have sterile drape. So initially, I did not have enough consumables, and I even had to do some EVDs with NG tubes, and it was all about adjusting to what I had. So how were the cases? The cases did not come easy to me. They came very complex. Even trauma cases, they were huge epidurals, even in Morocco, because Morocco had a high rate of trauma cases. I never seen complicated trauma cases. So some of the trauma cases were really complicated. Even the depressed skull fractures were on the sinus, and sometimes you had to do something, and it was a little bit challenging dealing with all these cases by my own. Tumor cases did not come easy on me. They came big, huge, and I had to do something. So I said I either fail or I start doing some cases. So I was getting advice and motivation from my former teachers. And, they all believed I could do something. So I started believing in myself. I said, okay, there's something I can do. But I believe one of the first advice I got from my former mentor, Professor Gentili, who unfortunately passed away, he told me, Claire, do not jump on crazy cases. Start easy, get confident, get the team to be working with you. And then no one really understands whether you're doing a chronic subdural, whether you're doing a big tumor. They all see brain surgery. So if you start easy, you get confidence, you can get the team around you, and they start helping you, and then you can take on complex cases. So this advice really helped me. So later in, I think it was last year, because I've been applying to this, I eventually got 2 WFNS sets, a spine and a cranial sets, and I got 2 drill sets, which really helped a lot. And I was able to sit at the table, negotiate with the administration, negotiate with the big boss, and say, look, a neurosurgeon needs a microscope. There's some equipment that are crucial, and we are about to buy our first microscope and endoscopic equipment. So how is the team? I started with access to 3 ER doctors, 4 anesthesiologists and critical care doctors, which had specialized nurses in the ICU. So our ICU has shared beds with other specialties, and we had about 10 beds. We still have 10 beds, 4 PQ beds, and surgical beds are still shared, and we get about 10 to 15 neurosurgical cases. But most of our patients, they come in, we do them, maybe they last 1 day or 2, and we have a big turnover. So they will be discharged maybe at day 2, day 3. And patients that are observed, maybe I observe them for 1 day, 2 days, and they can be sent back to their district hospitals. So that allows me not to have many patients sleeping in the hospital and congesting the hospital. So I try to keep only surgical cases that I can manage and do quickly. So we do have, since 2021, 1 additional neurosurgeon among the 3 local trained neurosurgeon who joined me. And since last year, we started having residents. So now I have a 1st-year resident and I have almost 5th-year resident. who helped a lot because the work was really crazy. I was sleeping in the hospital, continue consultation the next day, and do the job by my own. So with my colleague, we see about 2,500 consultation a year, and we see more than 1,000 cases maybe, and among them we will have probably 400 surgical cases, and we can easily do about 70 tumors, all kinds, pediatric, adults, and we're still probably unable to tackle some complex skull-based tumors, and we still have to send them to our colleagues who have microscope or endoscopic equipment. So I have access to radiology team with a CT scan. MRIs are done outside, but pretty quickly, if I want an MRI, I can get it the same week. I have a neurologist colleague, a pathology team. Since 2 years, we have oncology and run a neurosurgical center, which is set at the military hospital. Ophthalmology, we still do not have endocrinologists. So this is the Rwanda Cancer Center, where we have combined tumor boards. We do not have neurosurgical oncology tumor boards, but we meet different specialties, and we discuss our cases. And I think it has been a good experience having this kind of conversations about cancers and other tumor cases. So I'll be talking about my almost 435 in about 2.5 years. So you see that I do mostly trauma cases, and I equally do tumors and CNS malformation. This will include all kind of hydrocephalus, spina bifida, essentially, and we have infections, and we still do spine cases, but spine which do not require instrumentation. Sometimes we do instrumentation, but the insurance haven't really started paying for this, and it's still a big issue. We're still advocating for spine trauma because most patients will still not afford instrumentation. So tumor cases are many. On my list, I count about 70. I do mostly gliomas and meningiomas and other different tumors. My other colleague does more pediatric cases, but I also do some pediatric cases as well. So I will talk about some of the cases. So when I started, you will see, I believe that, well, I will not say that navigation is not essential, but navigation can sometimes be a luxury because this did not prevent me to start doing even big meningiomas. So you will see, I will look at the scans as long as I have a sagittal or axion, coronal, I will project the tumor on the skin. And I was really surprised by the accuracy in the beginning. I will open and straight to the tumor, and I was almost happy. I would say, well, navigation has been a luxury. So you see that we're able to do nice cases, parasagittal meningiomas. Some of the tips I learned during my fellowship: keep the veins when I can remove them by getting the attachment. Sometimes they come easily, but you have to see the surrounding. If you feel that you cannot get it very easily, maybe sometimes it's better to debulk them. Some of the meningiomas come to us really huge. This was a big parasagittal meningioma that I did with my colleague. You can see that invaded the bone, invaded everything, and the sinus and the dura. So we were able to remove it and to do a good reconstruction. A patient did really well. So I do also glioma surgery. I think that's the most common surgery I do. Most cases will present to me as probably grade 2, but we also have a lot of grade 3 and grade 4. I try, depending on the KPS of the patient, to offer gross total resection and gross total resection plus whenever possible, because I do not have access to any molecular profiling, methylation. So I cannot know if they are IDH mutant, if they are 1p19q co-deleted, which will probably give me additional information. So I try to do a gross total resection, and whenever I feel like I'm doubting, I haven't done everything, I will present to our tumor board. If we feel that patient can benefit from radiation and chemotherapy, we discuss, and then we take a decision. So some of the skull-based surgeries I'm able to do include anterior skull-based and middle skull-based, but lateral and middle probably sphenoid wing meningiomas. So far, medial and the clinoidal, which includes vasculature and nerves and everything, I try to send them for a microscope because I believe visibility is a key. So these are some of my cases. I think this was an OGM meningioma. I prefer to do them via bicoronal approach, so I can have a good visibility. I can still do them on the anterolateral corridor, but I feel like I will have a small corridor and I will not have a good visibility since I operate with my lobes and headlights. But I think if I get a microscope, I will probably be approaching them from the sides rather than from the midline. So this was more planum and almost tubercular cell meningioma. I usually I try to see where are the ACA branches. I look the angio. If I feel like it's safe, if I can devascularize at this base, and I can probably go around and debulk the tumor without compromising the vessels. So this one, I tackled it. Sometimes it's very good to think about the closure, open but think about the closure. So harvest the pericranium for closure, and by frontal intense hemisphere approach and get very nice results. So some of the cases come huge. This was more a frontal ethmoidal meningioma. I felt like I can do a bifront approach, but I opened unilaterally, so the tumor was protruding, and I was able to detach it at the cribriform plates and the forks and everywhere where it was attaching. So middle craniofossa tumors, they are sometimes a little bit challenging because they tend to go medially. I got this lady, she was really in bad shape. And look at this tumor, huge amount of edema. I thought twice before thinking that I could do it in my condition. I said, oh, maybe I can help her because I didn't have time. But before opening, I said, I want to see where are the branches, MCA branches, where do they pass? So I saw that MCA were coming above and across the, not inside the tumor, but above the tumor. There was this little vessel that was a little bit concerning. I said, okay, let me open. But when I opened with a huge flap. I said, okay, if she swells, maybe she will have room for swelling. So I drilled to the base and I got to the tumor, and I saw these abnormal vessels that were coming to the tumor, took them, and I was able with my lobes. So I always, try to get pictures so I can document everything I do. Try to see the ICA, and you can see here MCA branches and the optic nerve and some of the PCOM branches. So I was pretty happy. This patient did well. This is one of my latest tumor. I did pretty nice case. It's more lateral on the sphenoids, on the pterion at the attachments. I felt like, this is how I do, like, it's there, maybe I need to go down. And I believe the key is to get extradural devascularization before opening. So I did with my two women. So we're a team of women, and we're really proud. The meningioma came out pretty well, nice control, and the patient did well. So some of the pediatric cases, I chose this case because I think this was a challenging case I had. It was a trauma case. So this kid comes with an assault on the midline parietal area. So when I saw her, she had a wound, but I said, oh my God, this is going to be a little bit difficult. She was swollen. I said, probably there is a sinus injury here. What should I do? If I take this bone fragment, will I be able to repair the sinus? What am I going to do? I said, okay, because brain started coming out of the wound. I said, probably I can debride this area. So I was able to debride the area and able to close without tension. But look, 2 days, CSF started leaking, and some of the stitches, they really they got away, and I was surprised because kids can do really well despite having the brain exposed behind the CSF coming out. This kid was really good. I got another scan and brain was protruding. So it was really challenging. I would say, like, what can I do? How can I try to close? So I called my colleague Plastic. I said, maybe we can undermine and try to cover this part. And we went, but we were unable to do anything. So I remembered, you have brain, you have CSF. If one sector is swollen, maybe you can act on the other one. So I said, I think if I try to get an EVD, it will probably help me close. So I got an EVD, and look, brain sunk inside, and we were able to go back with plastic. So we did a rotation, and I was able to harvest some pericranium and cover the defect. And plastic did a non-full thickness skin graft, and the kid did really well. And the skin, yeah, well, it's not perfect, but it's at least closed. So I ended up shunting her, and everything closed, and it was challenging, but I was pretty happy, and I think I treated her in probably 3 weeks. So look at this next case: huge brain abscess, little baby. And I said, maybe I can puncture it. I punctured the abscess, but it looked like this baby had some malformation, because he had some sinus here. He had some anterior skull-base communication, and he had some duct here. So I went back and I did by coronal, and I looked for the communication, and I put pericranium and closed everything, and he remained with 2 small abscesses that we were able to treat with medical treatment. So and I got this huge tumor case, really nasty case, and this kid presented it to us, almost herniating. I was able to resect it with a good scan, but this kid had sepsis and had infection. They could not afford EVD and some of the antibiotics, and she passed away. So you can see that despite doing a good surgery, sometimes it may be difficult to do some of the cases. And then we get some of the huge crazy cases, and sometimes I feel powerless. So the challenges are many. Sometimes about doing more with less, and inadequate resources, like not having microscope, endoscope, and how to provide care with sometimes limited and poor people. So do you prioritize, say, okay, I'll be doing tumor or trauma cases, CNS malformations, or you can do everything? Because now I get very complex, even vascular cases, complex spine cases, complex tumor cases, epilepsy cases, and I believe they have to be done at some point. So I believe now we have basic training, but we also need to increase a subspecialty training so that if we get more subspecialists can tackle some of these other complex cases. And some of the challenges I was, always asking myself, so how will I keep growing? I'm still young, but sometimes resources probably are limiting me. Little time for research, little time for academic progression, guidance, mentorship. And I think in the first 6 months, it was really tough to get a momentum, tough to, to be able to tackle all these cases. But, I think studying abroad, having known all these people and having all these groups I belong to, also helped me, because I will call some of the colleagues, I will share some of my cases, and I get advice from everywhere. I worry sometimes about progression. I want to keep learning new techniques, and I want to practice techniques I've learned, like awake craniotomy, skull-based surgery, endoscopic skull-based surgery, because I always encounter cases that need this expertise. And the other challenge will always remain equipment, which costs a little bit, a lot for LMICs. Maybe we need to come up with cheap solutions for LMICs, but it will take probably a few years before we get there. Local integration, partnership, these are some of my colleagues. We do have some colleagues from UK, from France. We had our first endoscopic skull-based course in January 2022 on cadaver, and we're having ILCAD Africa being set here in Rwanda. So we'll be doing skull-based training on cadavers, and I believe that will help us advance. So there are no wins without fights and challenges. So as Pierre Corneille said, to vanquish without perils, to triumph without glory. I loved my challenges, and I still love them because they help me, and they help me every day to get better. And I believe I still have many years to improve myself, and I'm looking forward to it. And I'm really thankful for everyone who invested in my training, preparing me to be great, to be better. And all these men and women have many years of in their neurosurgical career, and I'm looking forward to have the same. So thank you. That was my lecture for today. I hope I didn't take a lot of time, but yes, that was it. Thank you.
Thank you so much, Dr. Claire. I think this has been a marvelous discussion and presentation over what has been your career and your development with all the barriers, challenges, and also the strengthening processes that had arrived to the point that you are now. And it has been very interesting to see how trauma is also a very important part of your load cases, of your caseloads. And definitely, as you mentioned, sometimes when you are dedicated to one subspecialty, like in this case, neuro-oncology, you want to have more time to be more dedicated to these complex cases. Sometimes the trauma or the amount of trauma cases give you to a burden that is really complicated. As you mentioned in your last slide, to prioritize these patients, because all the cases are really difficult, not only from the oncology perspective, but also all the other cases, as you mentioned, difficulties with spine surgeries, sometimes associated to the resources and things like that. So if you have the opportunity to select another neurosurgeon that are going to be involved in your team or something like that, which type of subspecialty you consider will be the most important in order to have like a better distribution of the caseload in this moment in your center? And also another question is related to, as you mentioned, when we are in this type of areas, we need to do everything. We need to work at the emergency room, we need to work in surgery, and we need to work in the ICU. So how you see at this moment this interaction, and you think that maybe having more advanced training for some trainees. You have residents now involving neurocritical care, for example, as a subspecialty, will be important. I just want to hear your opinion regarding this question.
Yeah. No, thank you so much, Professor Rubiano. So I try not to forget what I did in my my fellowship. I believe it's important to keep focusing on tumors, not forget them, but it's also important to do other cases, because when I'm on call, I don't choose whatever case I do. If a pediatric case comes, I will do. If a spine that I can do, and if any case I will do. So I think if to get another colleague, and my second colleague does more pediatric, but that's not his area of interest. And I still think that kids need a special attention. I think it would be interesting to get a pediatric neurosurgeon, but later also be interesting to get probably a spine, a neurosurgeon who will be dedicated his time for spine cases, maybe can advocate more on the equipment and screws and rods, so that patient get easily reimbursed when they have trauma, or even for degenerative cases, because there are so many and sometimes we're powerless in helping them. And I think if we can get our neurocritical care, our resident rotate in ICU for a period of about 3 months, so they know how. And sometimes we handle our ICU patient ourselves, but we are not doing it ourselves. We are working with critical care doctors. So I think if we can develop, maybe later, if we can have someone who did a fellowship in neurocritical area, it can be really interesting and it can help us a lot. So that's a relevant comment.
Okay, thank you. Yes, because knowing and understanding the complexity of the cases, we all know that maybe the postoperative care for many of those cases, it will be also challenging, and especially, as you mentioned, if you are running out of endocrinology service right now, many of these tumors are also associated, and even the trauma cases can be associated with a lot of endocrinology disturbances. So I think this is really important. I don't know, Dr. Rai, if we have questions from the audience at the moment.
We have a lot of appreciation with comments from the audiences. But anyways, thank you very much, Dr. Claire. It was very interesting, and ACNS look forwards to collaborative workshops as well as conferences together with you in Rwanda. If I may call upon Professor Shubin, who is here, the Vice President of ACNS, would like to say something.
Okay, thank you, Claire. And just like you mentioned, we hope you to be a professor very soon.
I hope so too.
You presented very, very good cases. Yeah, thank you.
Thank you so much.
Thank you. Thank you very much. With that, we come to the end of the first session, and I sincerely thank Dr. Andres Rubiano and Dr. Claire Caricasi for this very beautiful session about adapting to resources in neurosurgery. We'll move on to the second session. So I may call upon our chair, Dr. Ashish Kumar, who has been very generous about accepting our invitation, and we are extremely grateful to him. Professor Kumar, please take over.
Thank you, Dr. Raja. So it's first of all, thank you so much for the invitation. My passion for education, especially in relation to ACNS, goes back almost a decade now. So I'm just happy to contribute in whatever capacity I'm asked to. Coming to today's topic, I'd like to welcome Professor Wang Tao. And Dr. Raja has already introduced his credentials. I would just like to speak about the topic a little bit, because as a hybrid surgeons, we face this dilemma on case-to-case basis almost every day. Which one is better? Which one a particular patient needs? If the patient has equivocal features, what procedure to offer? Is it stenting? Is it endarterectomy, carotid stenosis, carries a major burden of stroke, especially in our area and everywhere actually, but more in North America. So we see a lot of patients with carotid stenosis which are symptomatic. We also see asymptomatic carotid stenosis, but that's a completely different topic altogether. But at this point of time, the usual consensus is to leave the asymptomatic carotid stenosis aside and treat the symptomatic one. And there have been so many trials for last, I think, 2 decades, where a particular study has given a favorable result in favor of stenting. A particular study has given a result in favor of carotid endarterectomy. But I think overall the consensus, and as the Cochrane review suggested as well, is more in favor of endarterectomy. But when we are actually at the ground and when the patient asks for minimally invasive procedure, so I think, in my opinion, a surgeon who does both is the best person who can answer both. And even if you are not doing endarterectomy, for example, me, I have not been exposed to endarterectomy during my residency. So, but there are my fellow surgeons who actually do it very well. So the more important part is to know when you don't have to put a stent and when the patient should be referred for endarterectomy. I would say that is very, very important. I would like to hear Professor Wang Tao's this interesting and excellent topic where I have a lot of learning to do. So I would like to invite Professor Wang Tao, and please enlighten us, as hybrid neurosurgeons, which way to take and how to counsel our patients regarding which is the better treatment modality. Welcome.
Thank you for your introduce. Let me send my PPT. Good evening. My topic is CEA versus CAS, regional choice of cases with severe carotid stenosis. I'm from Peking University Third Hospital. It is well known that China has one of the highest incidence of stroke in the world. Carotid plaque rupture and floating into the brain blood vessel is one of the main causes of cerebral infarction. And there are 2 therapeutic methods for severe carotid stenosis. Which one we choose? Carotid endarterectomy versus carotid artery stenting. CEA has a history more than 60 years. DeBakey was the first man to perform CEA. And micro CEA is a common surgical method for neurosurgeons. And American guideline see that in symptomatic patients, more than 50% of stenosis is a surgical indicator, and in asymptomatic patients who have more than 70% stenosis is the indicator. And CAS is new technology with a history more than 20 years. The indication for CAS, when stenosis more than 70%, too high to reach the stenosis, no stenosis, recurrent carotid stenosis, and too old, weakness cannot tolerate or refuse operation. And countering indication for CAS. For example, severe calcification or thrombosis, severe eccentric stenosis, tortuous artery, and extremely severe stenosis. The European and the Chinese guidelines are similar to USA. We can find a lot of articles on PubMed about CEA being gold standard, not CAS. Professor Zhou, the premier chairman of our Neurosurgery Society, he said CEA remains the first choice for the treatment of carotid stenosis. CEA is still the gold standard. And a study from endovascular talks about that investigator reviewed the discharge records of 124,000 patients with severe carotid stenosis in the US. Of these patients, 91% underwent CA and 9% underwent CAS. For symptomatic patients, the in-hospital mortality rate was 1.3% for CA, whereas 5.2% for CAS. In recent years, there are many international clinical trials on the comparison of CA and CAS. In general, CA has a slight advantage over CAS, but in some trials, the advantages of both are considered equal. In conclusion, for example, the famous trial CREST is conclusive. CEA and CAS have similar net outcomes, though the individual risk vary. Low stroke with CEA and lower MMI with CAS. Younger patients may have improved efficiency with CAS, and the lower patients have improved efficiency with CAS. Where does the balance of CA and CAS land? I've already performed CA more than 4,000 cases and the carotid body tumors more than 100 cases. And I have a dozen of hospitals to perform CA every year to popularize CA all over the country. And several hundreds advanced neurosurgeons from all over the country have been trained by me to further study CA in the last 8 years, including doctors from Taiwan and Hong Kong. Our feature is that with a small incision, less than 4 centimeters, the operation time skin to skin less than 1 hour. And the carotid clamp time ranges from 6 to 25 minutes, 15 minutes on average. No drainage, no caster. Patients move around the world 24 hours post-operatively. They transfer from hospital 4 days after operation. There are 2 surgical methods. We used more classic standard CA than Evosin CA. And my bypass rate is less than 1%, but some surgeons use such for every operation. Actually, I prefer to use carotid patch. I have experience with about 500 cases of carotid patch. This is pre-operative and post-operative CTA. The patch was applied. Only CA can be performed taking suture to repair intimal damage. And intraoperative, we use TCD, SEP, and near-infrared spectroscopic mirrors. Actually, we use mirrors more. Now, let's look at some cases of CEA and CAS. There are about case 19. Case 1. Well, preoperative left carotid artery stenosis with calcification, postoperative vascular patency. Case 2, the difference of CTA before and after CEA was very observant. CEA and CAS complement and reinforce each other in many cases. So, how to choose CEA and CAS reasonably? How to treat instant restenosis after CAS? Intervention, volume dilatation, stenting again, or stent and plaque were removed by CEA again. Patch angioplastic sometimes. Let me look at this some intentions. This case, case 3, instant restenosis. This case of carotid artery stent, the patient developed TIA again 6 months after underwent stenting. We can see 2 stents stacked up and down. DSA. Location is very high and very low. A long skin incision to explore whole carotid artery. We removed the stent and plaque during the operation. So we can see removed stent and plaque. We can see the plaque grows into the stent and post-operative ultrasound image. Post-operative widened artery. Case 4. The carotid embolic protection system umbrella was stuck in the stent when the interventional therapy in another hospital. The patient was rushed to our hospital by ambulance. We immediately moved the carotid umbrella and stent. We can see the carotid umbrella and stent. Then remove the carotid embolic protection system and stent. Finally, arterial cyst was removed. We can see the umbrella and stent. Carotid post-operative, the vessel is smoothly. Case 5. This man is a 81-year-old patient, developed TIA again 3 months after underwent stenting. We can see in-stent stenosis, still a small skin incision. This is a collapse inside the stent, post-operative. Left ICA patency. Case 6, this patient's stent located beginning of internal carotid artery. At the DSA, we can see the stent and plaque. The stent and plaque. The plaque grows into the stent too. Case 7. Case 7, the patient's stent located common carotid artery. Why the stent located common carotid artery still developed stenosis? This is a collapse in the middle of stent. Why? The plaque was very, very hard, like stone. It's hard, stone-like plaque. That's causing the stenosis of stent. Post-operative, the blood vessel was patent again. Case 8. This patient has symptomatic of amaurosis fugax with history of radiotherapy. Proximal stenosis, skin incision. The plaque was very hard, like stone. So we should assess choosing CEA rather than CAS for this hard calcified plaques. We don't suggest using CAS in the following cases: stenosis with severe calcification, unstable plaque, or vulnerable plaque, sand-like plaque, plaque with ulceration or hemorrhage, severe carotid stenosis with coronary stenosis with severe calcification. More suitable for CAS in the following cases. For example, carotid dissection. The carotid bifurcation is too high to explore. Intracranial stenosis, reinstenosis after CEA, pseudoaneurysm after CEA, fibromuscular dysplasia, carotid stenosis with severe cardiopulmonary disease cannot tolerate general anesthesia or severe cardiopulmonary failure. Let's see case 9. Occlusion or not. The patient was undergoing interventional therapy at another hospital when the right ICA was found occluding. But we can see there is a little blood flow in the late arterial phase. But revascularizing blood in his hospital. The neurosurgeon at the hospital referred the patient to me. The CTA of my hospital displayed the right ICA occlusion. the patient had a coronary artery bypass grafting. The right ICA blood flow was reconstructed successful in our department of by CEA. The right ICA blood flow was reconstructed. However, 3 months later, follow-up examination revealed the saddle aneurysm at the site of original vascular incision. Post-operative blood vascular was stained. Yes, we choose re-intervention to embolize the saddle aneurysm and place a stent at the same time. That means CAS failed, CEA revascularization successful. Then a saddle aneurysm developed. Choose CAS to stenting. Let me say case 10. Severe carotid stent with coronary stenosis with severe calcification, suitable for CEA, not for CAS. We can see the right ICA almost occlusing, and left ICA severe stenosis. And severe stenosis of 3 coronary artery with calcification. Simultaneous carotid artery carotid endarterectomy combined with coronary artery bypass grafting. That means CA plus CBG. Simultaneous operation, one anesthesia, one operation, brain and heart treatment at the same time. Heart surgeons and neurosurgeons were operating together. This plaque removed right plaque 2 days after operation and 6 days after operation. Right ICA was revascularized successful. Let's compare before and after surgery. And 1 month later, left CEA successfully. The blood flow was patent. And bilateral carotid arteries have good blood flow. The vascularization was successful. The patient was published in Journal of Chinese Neurosurgery. Let's see, case 11, severe calcification. Stenosis with severe calcification. The calcified plaque is very, very hard, stone-like, and difficult to cut. Just imagine this situation placed a stent can open the vessel. So we don't suggest using CAS in the following cases. Stenosis with severe calcification. The arteries are severe tortuous, twisted, and angled. Severe arterial sclerosis and severe eccentric. Long segment CCA occlusion. Let's see case 12. ICA twisted and angled, severe tortuous with hemorrhage. High resolution MRI showed the high signal. This means intraplaque hemorrhage. The bifurcation was like a ball. The plaque was transected and intraplaque hemorrhage was found. This case was not suitable for stent. We don't suggest using CAS in the following case. Case 13. Unstable plaque, mud and sand-like stick. The pre-operative CTA, the nasal initial segment if ICA was very small. Cut the wall of artery, plaque, which like mud and sand can flow. Mud and sand like plaque. Is not suitable for CAS. Now, let's see CAS 14, suitable for CEA. This case is right CCA occlusion. And we can't see blood flow in DASA intraoperative. Very long skin incision. And the moment the lower part of clotted common carotid artery was reopened. The plaque is about 11 centimeter long. Post-operative US. Post-operative ultrasound image. Post-operative blood vessel was patent again. Let's see case 15. Right CCA occlusion. The intraplaque hemorrhage may be the cause of occlusion of the common carotid artery. Post-operative blood vessel was patent again. The right CCA blood flow was reconstructed. Let's see case 16. Carotid subclavian bypass grafting, CSBG. If CCA is slender, atrial, and can no longer be used, or if the middle and the lower segments have been dissected or stents have been placed, artificial vessel or great sepherence vein, carotid subclavian bypass can be used. For example, subclavian artery to CCA, subclavian artery to ICA. 9 years ago, the patient has diagnosed with aortic dissection aneurysm. Due to sudden chest pain, he underwent thoracotomy. for the replacement of ascending aorta or aortic arc and active nasal stent implantation. At the same time, dissection was found to involve the right common carotid artery. So the lower part of common carotid artery is not working. We adapted carotid subclavian bypass grafting to reconstructed blood flow. Operating plan. Post-operative revascularization was successful. So a letter of thanks written by the patient when he was discharged. At 17, case 17, while the patient was repairing a car tire, the tire exploded. Explosive blew out the patient's left common carotid artery. The CCA was ligated and at the local hospital. So the common carotid artery is not working. However, the left CSGB is more difficult than right, because the left subclavian artery is lower to explode. Post-operative revascularization was successful. And post-operative revascularization was successful. We can see the bridge vessel is patency. And case 18, carotid valve. What's carotid valve? Carotid valve is a kind of fibromuscular dysplasia located at the posterior wall and characterized by a membrane-like lesion protruding into the artery lumen like a dark web. It's a fibrous tissue rather than plaque. Is CEA or CAS the better choice for the treatment of carotid valve? It is still debated, but I prefer CEA. CEA corrects the wall defect, yet does not require the patient to be placed on a longer-term dural antiplatelet therapy, and thus obviate concern about bleeding risk. Pathological specimen can be obtained for the post-operative pathological diagnosis or scientific research after CEA. But there is no significant difference in the incidence of short-term post-operative complications between CEA and CAS because of lack of large sample research. And the last case 19. This case was a 30-year-old man with carotid jugular fistula and saddle aneurysm formed after gunshot injury of carotid artery. Do you choose CEA or CES? Certainly choose CAS. Endovascular therapy, such as stent graft implantation, successful, block the fistula and saddle aneurysm cavity in another hospital in Beijing. However, instant restenosis, then occlusion, lead to treatment failure. 2 years after stent graft, the stenosis of proximal carotid artery near stent was found and gradually aggravated. During the follow-up, the transient amaurosis of his left eye occurred immediately, and in stent occlusion and severe stenosis of proximal carotid artery were performed by CTA in our center. We performed CEA and thoracotomy with heart surgeon, open neck and open chest. CEA with stent graft removal and end-to-end bypass using vascular graft was performed to reconstruct blood flow of left carotid artery. This is intraoperative monitoring. This is the surgically removed carotid stent and the thrombus in the stent. End-to-end bypass using vascular graft. This case illustrates a real CEA and vascular graft bypass in the treatment of in-stent occlusion following the gunshot injury to the carotid artery. The successful treatment of this real case provides an option to deal with this kind of tricky problem. First choose CAS, then choose CEA. The paper was published in Annals of Vascular Surgery. So, when we are dealing with carotid artery disease, CEA and CAS are not tit-for-tat animals. No, they are not like this. They are comrades in arms against the enemy, carotid stenosis or carotid disease. When we deal with carotid disease, we are faced with choice CEA or CAS. In fact, the indication of CEA or CAS largely overlap with each other. Neurosurgeons should make regional choice based on patient's specific condition. If both are suitable, then CEA is easy to remove plaque, low cost, low recurrency rate. Why not give it priority? Thank you. Thank you for your attention.
Thank you so much, Professor Wang Tao. Dr. Raja, there are a couple of questions in the chat, so I'll probably ask Professor Wang Tao. So Dr. Harshal Parekh is asking, how do you decide about the need of patch and direct suturing is not helpful? When do you use patch, when you not?
问您就是怎么样用那个补片和下面一个用那个分流，你说一下指针吧。
Actually, when the ICA is very slender, or especially stenosis, we usually use a patch to repair. And sometimes when radiotherapy, the ICA or CCA is very, very narrow. So the plaque is usually to repair the ICA or CCA. And
Yeah, like the nasopharyngeal carcinoma, after the radiotherapy, sometimes ICA was shrinked. So
yeah,
then you will use a patch, yes.
Thank
And
you.
when do you use a shunt?
actually, shunt, I use shunt less than 1%. And 10 years ago, I used shunt about 6%. But before operation, we elevation the various circles, and we have good monitoring. And the clamp time is very short. For example, 6 minutes is the shortest of my operation. So I use shunt only less than 1%. Thank you.
Thank you. So just to add on to that point, Professor Wang Tao, what we do here is whenever I do it with my colleague, because he's an expert in endarterectomy, we do it, we clamp it before and we wait for 5 minutes to see if there's any drop in SCCPs. If there's a drop in SCCP, we keep the shunt as a standby. But as you said, if you increase the blood pressure, very rarely you use the stent. Of course, you use the shunt, sorry. But of course, it depends on like our percentage is also close to like, less than 5% of cases. But if it is needed, then we just keep it as a standby.
Thank you very much. Another indication of shunt that we have observed when I was a fellow with Professor Kato is when they use the same NIRS monitoring spectroscopy. So when after putting the clamp, if the difference between the right and left hemisphere is more than 10%, they use a shunt for surgery. So that is one indication. Anyhow, thank you very much. It was really a very wonderful session and we learned a lot. Professor Shubin, would you like to say something?
Yeah, today I think is a very successful day. Now there's more than almost 2,200 audience attended the webinar. Thank you.
That is a huge number. Thank you.
Yeah.
Thank you very much, Professor
Yeah.
Shubin. So we'll wind this up and take the concluding remarks from Professor Ashish.
Thank you, Dr. Raja. Thank you, Dr. Zubin. Thank you, Professor Wang Tao. It was an amazing lecture, and you actually, pinpointed all the points which we usually use an indication and contraindication for CAS. And it's important to, to summarize, I will say it's important to make a decision at a place where you can offer both. So if you are a surgeon, you can offer both to the patient in an unbiased way, and that will differ when the same decision is made by a person from a different specialty. So I think that's very key, because you know the pros and cons equally. And as you said, if it's highly calcified, if it's really eccentric, and if it's really tortuous, you'd go for CEA. And probably that's the gist of it. So I'll say in summary, probably try to be a hybrid dual trained surgeon so that you can make correct decisions for your patients. Thank you so much. It was an excellent talk.
Thank you very much. Indeed, it was an excellent talk. Now it's time to wind up, and I would like to officially close this on behalf of the Education Committee of the ACNS and the President of CEO Cato. I would like to thank both speakers of today, Dr. Claire Kerkezi and Professor Wang Tao, as well as the chairs, Dr. Professor Andres Rubiano and Professor Ashish Kumar, for the time and support for the ACNS webinars. A very special thanks to our Vice President, Professor Shubin, for broadcasting this on the WeChat channel. And as he mentioned, there are around 2,200 people who had joined us live. So until we all meet again on next Wednesday, it is bye bye from all of us. Thank you very much for joining.